Hi, I'm Miranda Anderson, clinical nurse educator, and I'm going to talk to you today about chest tubes. Couple of things on chest tubes. First, CNAs will not do the output for chest tubes. That is a nursing responsibility. So if you have a patient with a chest tube, you're going to want to make sure at the every 8 hours that you're doing the output for chest tubes. Chest tubes, a couple of different things you're going to see. You're going to have an insertion chest tube inserted. This tube will be connected to the chest tube that's inserted to the patient. Usually it's going to be covered with silk tape, and then it's going to either have a bulky dressing on it or Mepilex, depending on who your surgeon is. We do not tear down chest tube dressings, only the surgeon does. So if you have drainage or you see some shadowing or drainage, date it, time it, outline it, track it. That way your provider can see how much drainage that they've had. Chest tubes will also have a clamp on them when they come to the floor. The clamp will need to be removed. We do not clamp a chest tube unless we have an order. So example, what Dr. Niehaus has done in the past is he will write clamp chest tube at midnight, chest x-ray at 6 a.m. because he wants to see in that 6 hours how they're doing. And many times then he'll make a round before 7 and take the chest tube out if they can tolerate it. But we only clamp a chest tube if we have an order. So when you take it off, many times you're going to find that they may be taped to the back of the chest tube, or they're put somewhere in the room where everybody has access to it if they would need to clamp the chest tube for some reason. The other thing you're going to see with orders on a patient that has a chest tube is you're going to see ambulation orders. What those doctors mean when they're ambulating is they don't expect the patient 4 times a day to walk around the bed where the suction reaches. You need to get portable suction to ambulate your patient in the halls so that they can start expanding their lungs and getting used to using their lungs more than what they currently are. So some basic functions of the chest tube. There is a stand here at the bottom, so this will turn out if you have it sitting on the floor. I do not recommend taping these to the floor as these patients will be going down for x-rays quite often. They really are quite hard to knock over. Just make sure that you kind of have it at the head of the bed. It's kind of away from foot traffic so that people realize that the chest tube's there. They also have these nice little hangers that you can hang on the bottom of the bed so that you have that availability or securement if you choose to do that. There is only one place for suction, and so when you hook your suction up, you have one port for that. Kind of the functions of it, when this is put in, this will probably be put in like an emergent setting where they can give the patient some sedation, or over in surgery, or usually where they're going to be placed. When they put one in, there is a plastic syringe back here with the fluid. They're going to fill the air leak chamber through the suction port, and that air leak chamber will have like teal fluid that will come up to this 2 centimeter line. So the 1, 2, 3, 4, and 5 are your air leak chamber levels. Couple of things, this should really be calm, should not be a lot of bubbling. If you have bubbling, that tells you that you have an air leak. I prefer when I have a patient with a chest tube to have them do a little cough, because sometimes you can catch they might have a little air leak on a cough. If that's the case, I might see a little bubble at the 1 on cough. And so then I'm going to document that, and I'll notify my provider that there's a slight air leak when the patient coughs. If this is bubbling clear over to the 5 and it's constant, call a rapid response. You need to get somebody there right away because their chest tube is not working. Okay. This little white ball will tidal up and down during inspiration and expiration. If your patient has a pneumo and that pneumo has improved or it's completely healed, that tidling may stop on inspiration and expiration. The setting for your pressures will be ordered per your physician. There's a little roller right here on the side that will adjust that NAS, that orange line right there. -20 is pretty standard. You might have a surgeon that does 30 or 40. It just depends. When I hook my wall suction, which will be set at low continuous, to my chest tube canister, there's a little orange accordion that will come out above this carrot to let me know that those levels have been reached. As far as output goes on these, we tape these off and we date them and time them. To get your output, you're going to subtract the previous shift's output from yours, and that will give you your shift output, and you're going to document those. Okay. The other thing is if this would get tipped over or it would fall over, it could have a fine crack and it's not going to work like it should. So you would need to change out your chest tube canister, or if it gets full, you're going to need to change out your chest tube canister. To do that, you're going to take the syringe to fill your air leak chamber. You're going to go ahead and set your level based off of what your doctor has ordered. You, at this point, can clamp your chest tube for just a quick second, and it's real easy to unhook them. There's a little button right here. I'm just going to pull them out. I would have gloves on, and you're going to then hook it into the new canister, move your suction over to the new canister, unclamp it, and then you are good to go with your new canister. Okay, so that is your chest tubes. Physician-driven, they're going to give you a lot of orders on as far as what your levels should be reading, as far as their pressures. Like I said, output for these are done by the nurse, so definitely make sure that you're doing that. Your CNAs can assist with ambulation. You will need to change over the suction for them, but otherwise that is how you work the Atrium chest tube. Thank you.